Hello, everyone. Like I said, thank you so much for joining us today and welcome to the Evolution of Care, Harnessing the Power of Your Immune System. I'm Dr. Dan Platt, and I'm the Chief Medical Officer at Gryt Health. And we have a great session prepared for you today with an amazing group of panelists, and I'm so excited to introduce them in just a few minutes here. This session is a collaboration with our founding partner, Bristol Myers Squibb, and we cannot thank them enough for their generous support of GVCC. Today, we're going to be talking about immuno-oncology. In the last decade, immuno-oncology treatments have transformed cancer care, bringing new hope to millions of patients. Immunotherapy harnesses the power of a person's own immune system to attack and kill cancer, which makes it very different from traditional treatments like chemotherapy. In this session, we will learn what immunotherapy is, how it works, and where research is going. Our hope is that you will leave the session feeling educated and empowered to discuss immunotherapy with your oncologist. As a reminder, we will not be giving specific medical advice in this session. All treatments should be discussed with your physician and your care team who are in the best position to treat you. We will be taking questions from the audience, and you can put your questions in the chat or use the Q&A button at the bottom of the screen. And we will try to get to as many questions as possible, but may not get to all of them. So just, again, please leave your questions in the chat and we'll answer them when they come up. Before we get started with the session, I'd like to first try to understand a little bit more about your familiarity, the audience's familiarity with immunotherapy. And so we're going to have a quick poll question pop up. When the question comes up on your screen, please click your response and then press submit. Okay, so the biggest one, slightly familiar. Okay, so sounds like we have a little bit of education to do, so that's great. I think people will get a lot of information about immunotherapy from this session, and hopefully you guys will feel much more comfortable with it by the end of the talk here. Okay, so next what we're going to do is we're going to take a quick look at a video from the American Cancer Society. Our friends over there, and we have Dr. Kantz from there who will be on the panel, and I'll introduce him in just a second. They've done a great job with educating patients, and so we're going to show you this short 3-minute video. It's just an introduction to immunotherapy.
Immunotherapy is one possible treatment your doctor may recommend. Immunotherapy is treatment that uses a person's own immune system to fight cancer by boosting or changing how the immune system works so it can find, target, and attack cancer cells. That's a general definition, but it's normal to have questions. Let's answer some of those. How does immunotherapy work? Some immunotherapy drugs help the immune system work harder and smarter to find and kill cancer cells. Others add to functions already found in the immune system. How is it different from chemotherapy? Immunotherapy boosts or creates a stronger immune response that can kill cancer cells, but usually don't harm healthy cells. Chemotherapy kills cancer cells but also harms healthy cells, so the side effects can be very different. How does the doctor know if immunotherapy is the right treatment? This depends on the type and stage of the cancer, certain tests, your overall health, and current guidelines and research. Immunotherapy works better for some types of cancer than for others. Sometimes it's used by itself, and sometimes it seems to work better when used with other types of treatment, like chemo. How soon should immunotherapy start? Your doctor or cancer care team will tell you how quickly immunotherapy should be started. How are immunotherapy drugs given, and where do people go to get them? Many are given at an outpatient clinic through an IV line as an injection or infusion. Some newer immunotherapy treatments may require a hospital stay. Others are given by mouth as a pill or capsule and can be taken at home. How long does treatment last, and how often is it given? This depends on the type and stage of your cancer, the immunotherapy being given, and how your body responds to treatment. Treatment may be daily for a few days, weekly, or monthly. Some types of immunotherapy are given in cycles, a period of treatment followed by a period of rest. The rest period gives your body a chance to recover. What are some common side effects? Side effects depend on the drug used and the body's response to it. Not all people getting immunotherapy have side effects, but some common ones are rashes, itchiness, flu-like symptoms, and diarrhea. Your cancer care team can help you prevent and manage side effects. What are good questions to ask before treatment? Every person is different, and not everyone will have the same response or side effects. Ask about the drugs being used, your treatment schedule, side effects you can expect and how long they might last, how to handle the side effects, and when you should call your doctor or nurse. To learn more, visit cancer.org/treatment or call the American Cancer Society helpline at 1-800-227-2345 to speak with a cancer information specialist.
Awesome. So really great video, a lot of information there. In order to kind of explain it a little bit more, I'd like to pull up an analogy and use a garden as an analogy. And Jess, if you could pull up that slide and I'll walk through it with everyone. So much great information there. But to better understand what immunotherapy is and how it is different, let's talk through the information here. So for this analogy, we can think of the human body as an ecosystem, and the ecosystem has to stay in balance in order for you to stay healthy. The soil of the garden is your immune system, and it ensures that the environment stays healthy and that the only good plants can grow and not the weeds, which are cancer cells in this analogy. In a person with cancer, the immune system is unable to stop those cancer cells, those weeds, from growing and spreading. And so soon all the healthy cells of the body start to be outcompeted for space and for nutrients, and the cancer starts to kind of take over. So different forms of treatment, you can think of them as kind of ways to return the garden to a healthy state. And you can think of treatment as the gardener in this analogy. So the gardener is going to do different things to try to get rid of the weeds, to try to bring the healthy plants back. So the first one, and you can look at this just to the right in that middle panel, is surgery. So surgery will remove a large patch of weeds and the soil around them in an attempt to make sure that the weeds don't grow back. So it takes out all the roots and everything. This can sometimes disturb some of the good plants that are close to the weeds, and it may also potentially leave some of those weed roots behind, allowing them to grow back. So one of the things that's important with surgery is to try to take as much as possible and make sure you get all the tumor. Chemo is like spraying a general weed killer on the whole garden. So this approach is going to kill a lot of the weeds, the bad cancer cells, but it's also going to harm many of those good plants, many of the flowers and other trees and things that are in the garden. And also the weeds may be able to resist some of that, the weed killer, and stick around. And because the weeds tend to come in like different types, cancer isn't just one group of cells, it's many different kinds of cells with different mutations. That chemotherapy may kill some of them, but not others. Radiation, and that's all the way in the panel on the far right there, is like using a magnifying glass and using the power of the sun to burn the weeds away. The problem that you can get with radiation is that sometimes the soil can be damaged right where the weed was. And so, if the beam kills the weeds, it may also kind of injure some of the soil. And that would mean kind of not being able to having a scar or things like that from the radiation. With targeted therapy, and that's right below radiation, you can see that the weeds are being directly sprayed with weed killer. So you're really targeting one specific weed or one little group of weeds. And the good plants that resemble the weeds, though, may actually also be hurt. So targeted therapy is much more specific, but it also runs the risk of having some side effects that are associated with the weeds and the healthy plants being very similar. But immunotherapy down there on the bottom is completely different. It's a totally new way of thinking about cancer care. Instead of targeting the weeds at all, what we're going to do is actually improve the soil. So immunotherapy is like adding a weed-killing fertilizer to the soil. And by making the soil healthy again, the hope is that the fertilizer will enrich the soil, it'll help to control the weeds, and it'll restore the health of the garden as a whole. Sometimes, though, adding too much fertilizer can cause things to get a little bit out of control. And so this would be kind of one of the side effects of immunotherapy, can be revving up your immune system too much. And sometimes the immune system can cause some side effects to that. So there's kind of a very fine balance there. Hopefully this was really helpful in terms of explaining how immunotherapy works. We'll be going into some more helpful detail with questions from the panel. And so with that, I would like to introduce our great panel of discussants today. So we have with us today, joining from a range of organizations representing different aspects of cancer care. Could each of you please briefly introduce yourself to the audience, starting with Cassie, and then passing it off to Dr. Kantz, followed by Dr. James. And again, thank you so much for being here, all of you.
Thank you so much, Dr. Dan, and greatly appreciate it. My name is Cassie Beisel. I am the Senior Advocacy Officer with the Melanoma Research Foundation. I've been here since 2014. I am also a 3-time cancer survivor, one of those being advanced melanoma in 2011. The other one was acute lymphoblastic leukemia in 2012 with a bone marrow transplant in 2013. Lastly, I was diagnosed in 2018 with 3 small spots of squamous cell carcinoma, which I was able to remove with Mohs surgery. It's a great pleasure to be here, and I'd like to now push it over to Dr. Kantz.
Thank you, Cassie. And likewise, it's a great honor to be here today representing the American Cancer Society. I'm the Chief Medical and Scientific Officer there. I've been at the American Cancer Society for just about 2 years. I'm a surgical oncologist, had an active cancer practice until I came here. And I also am a cancer researcher, have been involved in research my entire career, looking at actually various ways that cancers resist drugs and designing new drugs to overcome them. So a great topic with immunotherapy. Again, a pleasure to be here.
Great. Thanks, Dr. Kantz. My name is Lee James. I'm also an oncologist by training. I'm a medical oncologist. I am currently with Bristol Myers Squibb, where I've been for 3 years, and I head up our medical affairs organization, which seeks to help explain the data that we have to our external audiences. So it's really a pleasure to be here. In prior roles in the pharmaceutical industry, I've also helped develop new therapies for patients with cancer. Thanks very much. Back to you, Dr. Dan.
Thank you. Thank you all for being here. It's such a great panel, so I'm really excited to get started. This first round of questions is going to shed some light on the evolution of cancer care in the last decade, and we're going to talk about some of the innovations and advancements that have been made with immunotherapies. So as we've seen, and as all of the patients in the audience can attest to, over the past 5 years, cancer treatments have changed significantly and advanced really rapidly. So Cassie, I'd like to start with you. How has immunotherapy impacted the landscape of cancer care for patients?
Thank you, Dr. Dan. When you talk about impacting over the past 5 years, treatment cancers for patients and immunotherapy, one word comes to mind, or I guess 2 words: increased hope. So, for example, when I was diagnosed with melanoma back in 2011, there was only 2 types of treatments available at that time. One of them was one of the earliest stages immunotherapies out there, but it only gave me a 15% chance of survival through that. And so I'll never know whether it was that early stage immunotherapy that really staved off my melanoma diagnosis, or whether or not it, was that plus the resection of my melanoma in my lymph nodes. But really these days, we went from one treatment for all to precision medicine for all is really how we're looking to going, which is, again, working, with a person's own immune system. And as you said in the garden analogy, really fertilizing and enriching that soil to best target and treat these patients. I think, this hope is coming from, longer life, better quality of life for most patients, and feeling the ease of knowing that medicines are more tuned in for a particular patient's body than just one for all type of method.
Absolutely. Thank you for that response, Cassie. I think immunotherapy, what we're seeing for patients is just this amazing space and this amazing opening up of a new way of treating patients. Dr. Kantz, I'd like to ask you a question. In what types of cancer has immunotherapy had the most success? And what types has it had the least? And why is there that difference?
Thanks, Dr. Dan. Very good question. And if you look back, first of all, we've been hopeful that the immune system would be able to be stimulated to attack cancer for a number of years. One of my favorite books, actually, from the 50s is The Spontaneous Regression of Cancer, where cancers actually were proven to exist with a biopsy and proven to go away. And if you look there, the 2 most common types where that happened for melanoma and kidney cancer.
Hmm.
So fast forward now, those two have very high success rates with immunotherapy, or say some of the highest success rates. Other areas are lung, bladder, some of what we call the liquid tumors like lymphoma. There's been efficacy with immunotherapy there. Breast cancer, colorectal cancer, we've not seen the same effects yet. And overall, even in cancers where it's very effective, we still have a ways to go. So why is there this big difference? And we don't know exactly why, except there are multiple mechanisms that the tumors have used to evade detection. Tumors, I think of cancers as these shameless criminals who are on the run from the law. And the law is Mother Nature. Mother Nature tries very hard to kill any cell that's not where it should be, which are cancer cells. Unfortunately, the tumors can actually put force fields around them to protect them from drugs, from immunotherapy. They can actually block the patient's own immune cells from killing them. So I think there are a lot of other mechanisms that the tumors use to evade detection and to grow. And that's the area we'll talk more about with where the research is headed to get even better, more effective immunotherapies.
Yes, Dr. Kantz, it's a really interesting space because, as you said, it's seeming that it's really useful for some patients, and there hasn't been that quite global use across different cancers. But I think we're seeing that potentially in use of combinations, and also we're really learning a lot about tumor biology and about kind of the space the tumor occupies. And immunotherapy is really increasing our understanding of cancer in general, because of all these new things that are popping up with still having some resistance to the immune system. So thank you very much for that response. Dr. James, I'd like to pass it over to you. What is being done to expand the reach of immunotherapy to more patients?
Yeah, thanks, Dr. Dan. It's a great question because the benefit that we've seen in some patients, we're so excited about it and patients are so excited about it that we want to bring that benefit to more patients. I think part of it is what Dr. Kantz alluded to with reaching tumor types that have been more difficult to treat. So one way to do that is combinations. In that great garden analogy, we saw that there were different distinct types of treatments. And a lot of the exciting developments over the recent years are thinking about using two or more of those now together. So we see combinations of immunotherapy with immunotherapy, immunotherapy with chemotherapy, immunotherapy with radiation, immunotherapy with targeted therapy. So I think if some pathways are limited, it's possible that we can combine those together in order to reach more patients who have different tumor types. There's another way to think about the reach of cancer care. Just two quick points. One is what we call earlier stages of cancer. So a lot of the treatments that were developed in patients who had disease that had spread. And I think an exciting development is reaching patients whose disease had not yet spread, but where these kinds of therapies may be helpful. And then a third quick point is about bringing the medicines to a more diverse population. I think we're all interested in seeing expansion in diversity in clinical trials and making sure that more patients have access to these medicines and advances. Thanks.
Absolutely. Dr. James, you bring up a great point of moving therapies earlier in the treatment paradigm and getting them to patients earlier. So, of course, most cancer treatments, they come in at a later stage in order to prove that that they work in more advanced patients, but getting them to patients earlier in disease, testing them so that they can potentially prevent cancer from recurring, and also the hope that earlier use of immunotherapy will lead to better outcomes is really exciting. Dr. Kantz, I'd like to bring it back to you to ask, what is the potential of immunotherapy to continue changing the landscape of cancer in the years ahead?
It's a great question there, Dr. Dan. And going back to Dr. James' points, I believe that the early stage, as you just mentioned, and the ability to combine with these other therapies is going to be very, very important. That opens a huge landscape ahead. And then the diversity in the clinical trial space, not everyone may respond the same to immunotherapy. We don't know what the mechanisms of response are. So the landscape will a big part of that will be figuring out who's going to respond and who's not. And maybe it has a lot to do with the tumor. Certainly the tumor itself will have much to do. Maybe it has something to do with your immune system. Maybe it even has something to do with the microbes, bacteria in your gut. There's more and more evidence is pointing toward the microbiome as playing a role in cancer. And as we move forward in this space, we're in this amazing industrial revolution, converging biology, physical world, and the digital world. So we're getting so much data now. And as we look at those data and track all those data, then I think we'll find it more opportunities for immunotherapy as well, while we still understand some of the basic mechanisms of why some tumors respond and some don't.
Absolutely. That's a really great point. Thinking about the body as an environment, and I think we're thinking a lot more because of immunotherapy and activating the body brings in ideas like the microbiome, like you were mentioning. What role do bacteria in our body play? We have so many bacterial cells. I think a lot of people don't really recognize that bacteria make up a huge part of our body and play a huge role in disease and in health. So some really interesting things that are going on with research. For the second round of questions, I will be discussing the advancements that have been made in immunotherapy and personalized therapies. So immunotherapies that we've been talking about, they represent this really exciting field of research. They've brought about significant change in delivering improved long-term outcomes. They've expanded our understanding of the underlying mechanisms of cancer, as we've mentioned, and in how it can be treated. So in addition, the field of personalized therapies, so using targeted therapies, which kind of overlaps with the immunotherapies to some extent, including cell therapies and CAR T you may have heard of, which is really exciting as well. It's rapidly growing. It's transforming how treatments can be manufactured for and delivered to patients. So Dr. James, bringing it back to you, how have immunotherapies and cell therapies changed the standards of care for cancer? How do you see the use of immunotherapies and cell therapies evolving over the next 5 to 10 years?
Yeah, thanks, Dr. Dan. I think there are some elements when we think of standard of care that sort of haven't changed. So the way that we approach conversations with patients about what is the diagnosis, what is the prognosis, and what are the treatment options. And so there are fundamentals that kind of underlie all of what we do. But what's really developing and changing every year is the science behind those conversations. I think there's a lot of science to understand how tumors work, how the immune system works. When we think about some of these developments in immunotherapy, these have been awarded Nobel Prizes recently, right? This is a fundamental change in how we're understanding our own biology. And as we use these treatments, we're going to continue to learn about the biology. And that learning is going to help us then understand more pathways or more potential. So I think that there's a science-based approach, which really enables us to think about the problems that are ahead of us and what we can do. One example of that might be immunotherapy resistance. As more and more patients are treated, we also know that not all patients respond. That represents a real challenge and an opportunity for us to learn more.
Absolutely. Thank you for that great response. Cassie, bringing it back to the patient perspective, how have immunotherapies and personalized therapies changed the patient treatment journey? And has it been difficult for patients to navigate as new treatments continue to emerge?
Yeah, absolutely. Great question, Dr. Dan. And, breakthroughs in immunotherapy have led, ultimately overall to better quality of lives for many different types of cancers. And in fact, since, the early days of immunotherapies going back 15 years, there has been, progress to show that there has been success in 15 different cancer types, including lung, head and neck, bladder cancers, kidney cancers, Hodgkin's lymphoma. And it's really gone a long way in improving quality of life, even times, depending on how it's working with the patient's immuno-oncology system, is that it's, sometimes you're seeing even less of side effects than you normally would. But then, as Dr. Lee mentioned, that there is that problem of the possibility of, tumor resistance to the immunotherapy. And so these breakthrough treatments are not only getting better, but they're finding ways to kind of make this better for the patient going forward. And although the rise in patient support from advocacy groups like Gryt and the MRF have increased the education of immunotherapies for patients over the years, I still think there's still a lot of work to be done in educating and empowering patients, not only ask the right questions to their provider, but feel confident that they have a role in the decision-making process of the treatment path. The cancer diagnosis is extremely overwhelming to both the patient and to the caregiver. And our education and the education of the provider needs to be really simplified and made clear to the patient very early on in the diagnosis. And I think as that continues to happen, we'll really see a change in the shape of better outcomes for patients, a better understanding of what they're going through, and to kind of how to tackle, the side effects of their care in this partnership with the provider moving forward.
Absolutely. Thank you for that great response, Cassie. Dr. Kantz, bringing it back to you, what would it mean to be able to have personalized medicines for all patients living with cancer? Is that a feasible reality? Is that something we're going to be able to achieve in the near future?
So, thanks, Dr. Dan. That is a goal that we really would like to see, and I do believe it is achievable. Personalized therapeutics. And I believe we're moving much more toward personalized therapeutics rather than, you have a breast cancer or colorectal cancer, so you always get this treatment. It's more, what does your tumor have, and what does your body have? So it's the whole, what's in your garden? What do you need? And I think, first of all, the technologies are getting so much broader and have come such a long way. So we can sequence the tumor genomes very quickly. So and also, in addition to that technology, an equally important point was the cost is relatively low. So it's a quick, relatively low cost, but its personalized medicine will extend beyond the tumor genome. It's going to extend into the person, to your body, to how you all the factors of the garden. So I do believe that is coming, and more and more quickly. And I believe that the technologies will also make it easier to get the cancer care to everybody, because I think as we refine these and we get better at understanding what the tumor is going to do, we will be able to give care to everyone. And finally, we all want a cure for cancer, right? We've been talking about a cancer cure for years and years and years. The magic bullet. Where is that magic bullet? And we are curing a lot of cancer now, no question. But we have a ways to go. So can we take the cancers that where we can't cure them, but we control them? So we turn them into a manageable chronic disease, like a diabetes. You live with this. And to do that, personalized medicine is going to have to be a part of that. How did your tumor change? Oh, it started to grow a bit. Well, now we can attack this pathway and give you these drugs or this immunotherapy. So that's where I believe you see the personalized approach being even more effective.
Yeah, great point, Dr. Kantz. There's a coming age where people will get frequent genetic testing and different therapies will be applied at different times. And it's really exciting to think that, in the near future, cancer will be able to be controlled, will be able to be managed like a chronic disease. And we're not too far off from there. We have some great targeted therapies and the immunotherapies we're talking about today. So it's a super exciting time in cancer research. The third round of questions that I'd like to cover with you three is talking about some of these latest breakthroughs. We've mentioned some of these cutting edge research in cancer, but if we can go into a little bit more detail, I think this is such an exciting space. So research in cancer care has become so advanced, and we're seeing the use of partnerships, of data sharing, as you mentioned, Dr. Kantz, and big data, machine learning, and other sophisticated approaches like genomic sequencing. to deliver critical insights that inform the development of new therapies and technologies. And this is allowing for innovation to happen and guiding next generation therapies. Dr. James, as as someone who's bringing treatments and new treatments to the table every day with BMS, what are you currently most excited about in cancer research, and what is being done to improve the response to immunotherapies even further? I think you're on mute here, Dr. James.
On mute. I knew it had to happen once, so maybe I took one for the team as a reminder to us all. Great. So thanks, Dr. Dan. When I think about the exciting technologies, the things that are brand new that we're really beginning to learn more about, I think about cell therapy, which falls in this larger category of immunotherapy. Cell therapy today involves taking immune cells from a patient's body, modifying them outside of their body, and then giving them back to that same patient. That it requires a lot of technology and a lot of technological advancements, like Dr. Kantz talked about, but it also represents the potential for benefit for patients in a way that we've never been able to do before. So I think about the future because we're just at the very beginning of that journey. And I think every year we're going to see new advances and new medicines and new understanding around that. I think there are some other tools that we have around the immune system, like antibodies that don't do what they normally do, but we can modify antibodies to have an effect on the immune system and bring certain cells together that may not have bumped into one another naturally along the way. And I think that's another very exciting direction, and hopefully, again, better outcomes for patients through science.
Yeah, absolutely. Dr. James, we were referring to, and I think many people in our audience might have heard of it, chimeric antigen receptor T cell therapy. So taking those immune cells and making them even more potent. So in a way, it's taking individual cells in the soil and making them better able to find those weeds, to find that cancer. And the other thing you mentioned, of course, ways to kind of hook two cells together to bring those immune cells closer and be able to kill cancer even better. These are really, really exciting spaces. So thank you for that. Dr. Kantz, how can we accelerate and optimize current research taking place to advance these breakthroughs even more quickly for patients?
It's very critical that we increase the pace and discovery, but really discovery to patient. So there's so many discoveries that are made that don't make it to a patient, to a drug, to a new approach for a lot of reasons. So I think one thing that we need to do is to look at those exciting findings that are right at that preclinical stage, just before the patients, and catalyze that we call that in research the valley of death, because discoveries fall off and go away because they're not catalyzed. And this is an area that the American Cancer Society is very interested in pursuing. At the same time, I believe the clinical trial piece could be made easier, simpler, and more diverse. So how we can be innovative in how we design clinical trials. Of course, we obviously hold to extremely tight ethical standards. Still, we need to be able to get those drugs to the patients even more quickly. And then finally, I think for the disparities that we know are in cancer care, we want to focus there, of course. To do that, we have to focus also on the workforce that takes care of those patients. So the more that we can do to launch and sustain that workforce, to get people out there who are the trusted messengers in communities where we see disparities, so that we can accelerate the pace of discovery and implementation. So those are the three separate areas that I believe we really need to focus on to accelerate this to the patient.
Absolutely. Dr. Kantz, I think you bring up a really great point, which is right now, only something like 2 to 5% of cancer patients actually participate in the clinical trial. Things can't be brought forward unless we are able to actually test these drugs, these new combinations, to test these new treatments in patients. So I know that Bristol Myers Squibb is doing a lot of work to try to increase diversity and also speed and accelerate that work by getting it to patients sooner. But this is really, we ask the audience for help in research. We ask you as patients to step forward and become part of clinical and patient experience research so that we can better understand and better get treatments to you more quickly. Dr. James, I don't know if you want to comment on some of the tactics that, as a pharmaceutical company, and with the ACS, Dr. Kantz, what can we do? What should patients know about trying to get into a cancer trial, trying to get into research so that we can advance these treatments more quickly? And Cassie, I would love to have you comment on as well from the patient standpoint. How do we bring patients into the system? How do we make them a part of being able to talk about trials and help design them and feel more comfortable with it? So maybe Cassie, we can start with you.
Sure, absolutely. And I think that is an excellent point. It was something I was going to address in a little bit. But I think when it comes to clinical trials, a lot of times, I don't know if even us as an organization or whatnot, really let the patient understand that a clinical trial doesn't have to be your last line of treatment. It can absolutely be your first line of treatment. Also, I mean, there are so many myths and misconceptions out there about clinical trials and what a patient is going to be, whether it's, oh no, I'm only going to get a placebo, I'm not going to get the treatment for me, or, no, I really don't think a clinical trial will be my best form of treatment because it's new and exploratory. When look, with all of these clinical trials that we have now have been bringing these breakthrough treatments to the US population and beyond for the past 10, 15 years. And a majority of them have been groundbreaking and have really taken us to the next step of where we need to be in personalized medicine. And the people that have been on these clinical trials have been absolute pioneers in the patient community. And I think we really need to dispel those myths and those misconceptions and start talking about clinical trials as a possible first line of treatment for patients and making them feel more comfortable with that. And so I really, I hate to say this, but I really don't know if we're doing our job well enough yet with the patient population to have them understand that.
Yeah, great points, Cassie. I mean, it's an educational thing. It's also people thinking that this is experimentation, but it's moved well beyond that. Oftentimes, the best treatments are ones you can find in a clinical trial. And again, as we mentioned earlier in the session, a lot of times maybe getting some of those treatments, those more advanced treatments earlier can lead to even better results. So getting patients almost as quickly as possible and getting as many patients as possible into clinical trials is really a great path forward. Dr. James, Dr. Kantz, would you like to comment?
Thanks, Dr. Dan. Maybe 2 points to build on some of the things Cassie talked about. One is the way that we partner at BMS with other key institutions and groups, patient advocacy groups, cancer societies, in order to help them amplify and tell their story. I think having patients talk to other patients, having trusted organizations talk about the value of clinical trials and the role of clinical trials really is a benefit to everybody. So we're very actively engaged with our friends in the sort of broader group trying to advocate for patient trial enrollment. I think another point is about making trials more patient-friendly. BMS has pioneered something called PEERS. It's an acronym that just is about making sure that our phase 3 studies, our large studies, are reviewed by patients before they get finalized. And so making trials patient-friendly or having a patient voice, even in the design of the study, is going to be critically important to having that study be the most successful it can. And so I think there are a number of opportunities along the way to tweak and improve what we do in order to make trials more accessible and a better experience.
Absolutely. And I know you guys are doing great work to speed things along. Dr. Kantz, at ACS, are there any initiatives that you guys are working on to really move things forward?
Yeah, we are interested in expanding access to clinical trials, and we're sorting through various approaches as we evolve our patient support strategies. I wish I had a good answer. I wish I could solve this, and I think it's multifactorial as it's been described. I've sat in more conversations with patients who say, well, that means I don't get therapy. And I'm like, no. This is what it really means. So I think there's an education for patients, as we've mentioned. I think that the trials need to be simpler, as I mentioned, easier to enroll. And also, when you see in community oncologists many of whom are so busy that it takes a lot of extra time and effort, responsibility, and so forth with the clinical trials. And we have to figure ways of making that easier for them to be able to talk about clinical trials and give them as first-line therapy. So I think there's a lot of that education, and then the disparities piece. There's various matching, there's algorithms, programs. As we get better with digital retrieving information from the electronic health records, taking that digitally, I think we'll have more opportunities to find those trials. So I think that's another approach. But I don't have one single approach that's going to be multifactorial, and the American Cancer Society is very interested in pushing that forward as our role as the trusted messenger, a trusted source of information.
Yeah, Dr. Kantz, thank you for that great response. I think people forget that something like 60 to 65, 70% of cancer patients are treated at community centers, and reaching those places and making people at those centers feel comfortable with research is really, really important. The major cancer centers in this country do a great job and run many of the trials, but how can we expand? How can we give more people access in order to find those trials and speed things along? So great points. Thank you, everyone. Cassie, I'd like to come back to you. So all the scientific advancements that we've been talking about here, they're being made with the goal of improving patient outcomes. What aspects of treatment and care are most important to patients that must be kept in mind when developing these strategies and these therapies?
Yeah, another great question, Dan. You're full of them today. I love it. I think, patients really, and I'm not going to speak for all patients because, again, everyone is individualized. And even though patients can have the same exact cancer with the same exact effects, it's every patient is still different, right? And so I can't really speak for all, but just kind of, working in the space and being a thriver myself, I really think patients want a relationship with their doctor that is very inclusive of their treatment plan and what's happening, and to be able to know what all of their options are early on in the diagnosis area. And it's important to keep in mind, I think, the need for quality of life when patients are going through their treatments, whether it's minimizing their side effects, longevity of treatment, or finding the most personalized treatment for them that offers the best chance for survival, while not overall affecting your quality of life. I think the patient wants to share, and I think it's very important for the patient to share their experience, because without sharing your experience and being honest in what's happening during your treatment cycle, we're not going to be able to, really directly impact those for the better. So I think it's this relationship that the doctor and the provider and the patient are in this together as a team. And, as again, we're coming more personalized medicine these days, but I think that involves a more personalized relationship with your care provider at the same time. So I think including them in, drug development, clinical trial access and development, and just garnering their experience through it all is really going to be the most important thing moving forward.
So true. There's so many more touch points now that patients can interact with with the healthcare system, with doctors. Telemedicine has been really helpful. We're moving towards a kind of a more decentralized clinical trial process. I know BMS is a pharmaceutical company that's at the forefront of making that happen, being able to really simplify trials for people so that more people can participate. So thank you so much for that answer, Cassie. I'd like to take some time and address some questions. Jess and Beth from Gryt, I'm actually unable to get to the chat to see what some of the questions are. Maybe you guys could jump on and tell me what some of them are so I can get some of them addressed here if we have some.
Sure, Dan. So the first one is, does immunotherapy work with chronic myeloid leukemia? I am currently taking oral chemo medication, but the percent of my leukemia cells have been going up slowly but gradually.
Okay, so that question once again was, does immunotherapy work with chronic myelogenous leukemia, or CML? And we have a person on the line who's actually progressing a little bit. Dr. Kantz, Dr. James, would you like to jump in and take that one?
Dr. James, you have more expertise in the CML realm than I do.
Yeah. Okay. So I think there are certainly some tumor types that are more responsive, and I would say some of the chronic leukemias don't fall into that category. So it remains probably an area of work to do. I can't offer any specific medical advice, but I think there are technologies like clinicaltrials.gov that allow patients to go in and put in their cancer type and look at available therapies. Our focus today obviously is immunotherapy, but it's not going to be the answer for everybody. There are a number of really exciting new therapies. And as we talked about, finding out what available clinical trials might be could be a best path forward.
Yeah, and great point, Dr. James. It's really a matter of, as we've been talking about, immunotherapy works differently in different cancers, and some of them there's been great success, and others there's actually been more success sometimes with targeted therapies. And CML is a space where there's some really there's some good treatments, but we're in a situation where there are some advancements that need to be made still. So I think great answer. And again, we can't offer medical advice on this, but it's a really important area. Go to clinicaltrials.gov to find out more information if you can. Also, there are other sites that can be really useful. One of our partners here, Ancora AI, does a great job with simplifying things like clinical trials. So that's a great tool to use if you're looking for some clinical trial information and also trying to find information about immunotherapy. You can also go to websites like BMS and see what they're doing with immunotherapies and check and see if they're working within your cancer type currently. So a lot of different resources out there, and navigating them is something that we love to do at Gryt Health, so we can help you with that as well. Any other questions, Jess, that we can answer?
Yeah. Are monoclonal antibodies like Herceptin immunotherapy?
Okay, so yeah, Herceptin. So we have a question about Herceptin, which is a targeted therapy. So immunotherapy is slightly different. So immunotherapy is really activating your immune system. Herceptin is something that a targeted therapy that blocks a receptor that prevents cancer from dividing. Dr. Kantz, I don't know if you want to kind of talk a little bit about the difference between targeted immunotherapy to help patients kind of better understand the difference there.
No, I think you answered it well, Dr. Dan. That's a targeted therapy. It does rely on it is an antibody is technically what our bodies make in the immune system. So they're very easy to confuse the two. So immunotherapy, it takes a variety of forms. It can block certain proteins that the tumors make that inhibit the immune system, or it can target the actual immune cell to make it more responsive. Immunotherapy has this balance, like with checkpoint inhibitors. It's a balance between turning it on enough, but not turning it on too much, so it attacks normal cells. That's one of the side effects. So there's always that balance with immunotherapy. But immunotherapy can be a number of different things. In the old days, it was interferon to stimulate your immune system. It's kind of a non-specific way of doing that. It was this attenuated tuberculosis bacteria called BCG. I spent a lot of time doing trials with BCG and melanoma patients in my medical school days. And now we're looking at actually those CAR-Ts. Should we engineer a patient's own cells, immune cells? Should we put special genes in there and expand those cells and let them go attack? Should we actually take out a tumor that has a lot of lymphocytes around it, presuming that those are the ones trying to attack, and expand those? Those are what we call tumor infiltrating lymphocytes, or TIL therapy. And you're going to see more and more approaches to TIL therapy as we go forward. So lots of those are all in a bucket. And I believe going back to the point of the combination of targeted therapy plus immunotherapy, that's where we'll be seeing, I suspect, a lot of progress as we move forward. Yeah,
Dr. Kantz, I think you really explained it very well there. There's this big potential advance of combining something like Herceptin, a targeted therapy for breast cancer, with potentially an immunotherapy that boosts the response of both. So those are the kind of studies that we want to do. There's so many drugs out there now and so many potential combinations that there's the clinical number of clinical trials looking at them is just getting more and more each day. And the more we can get patients into those, potentially the faster we can advance them. So great question. Thank you for that. We have time for maybe one more question that we can quickly get to. Jess, do we have maybe one more?
Yep. Are immunotherapies easier on people than chemotherapies?
Great question. Thank you for that one. So, we kind of used that garden analogy earlier, which showed, we talked about how chemotherapy is like spraying a generalized weed killer and it kills a lot of healthy cells. So that's why when people are exposed to chemotherapy, they get things like sores in their mouths. They, a lot of times, will have skin issues as well as lose their hair. That's because chemotherapy kills rapidly dividing cells, but cancer is a rapidly dividing cell, and your hair follicles are also rapidly dividing cells. Immunotherapy is different. Maybe Dr. James or Cassie, maybe you can talk through a little bit about kind of that difference about why chemotherapy may have kind of these worse side effects, and maybe immunotherapy can be a little bit more targeted.
Yeah, I think maybe the place I want to go is to emphasize that not all chemotherapy is the same, and not all immunotherapy is the same. And it's tempting to want to put them in buckets and say chemo bad, immunotherapy good. But I think there in reality there's a lot of complexity, and so lots of different kinds of chemotherapy, some with fewer side effects, some with more side effects. Lots of different kinds of immunotherapy, some with more, some with less. So I think the overall picture is really about benefit risk, which is how much benefit might an individual get versus what are the particular risks that they might be facing. In talking with people, I often encourage them to see that long list of side effects and think about them maybe in two flavors. One are, what are the things that are common but may not be very dangerous? And also to understand what are the things that are uncommon but might be very serious. And I think rather than taking a list of every potential side effect and actually thinking about them in terms of how likely they are to occur and what the consequence of them is, may be a helpful approach for anybody, regardless of what therapy they're thinking about.
Yeah, great point, Dr. James. This immunotherapy represents an advance, but there's going to be a space for all the different treatments that we've talked about. And chemotherapy is still a really important treatment that's very effective for a lot of patients. So it's easy to think about immunotherapy as kind of that there's this movement forward, but we're still using the same kind of things that we used 50 years ago. We're just getting better at using them. We're getting smarter about when and how we use them. So thank you all for a really interesting discussion. I think we might be out of time here, but thank you, audience, for all your great questions. We really appreciate it. And to my great panelists here, Cassie, amazing speaking with you. Dr. James from BMS, you were so helpful in explaining some of these key points. And of course, Dr. Kantz from American Cancer Society, we really appreciate you being here to explain what we're doing from a wider scale to help make treatment better. I want to potentially, I know we got to sign off, but I just want to say, maybe I can leave the last word with Cassie as a patient, as someone who has been through a number of treatments. I think for our audience today, one of the things we've seen is that there's a need to still feel empowered and educated. I wonder if there's kind of maybe a final word that you can say about ways that you feel you can empower patients to be their own advocate, to ask for some of these treatments, and hopefully, to learn more about them.
Yeah, thank you so much, Dan. And just before we sign off, I want to give a thanks to, Dr. James and Dr. Kantz as well. It's so great to see the patient voice alongside voice as we go into the future here with immunotherapies. But I think one of the most important things to know as a patient is that, cancer for me, when I was diagnosed those many times, I had to give my life over to cancer. It was taken by science. My life was no longer my life. and it's hard to understand in the moment, but you still have power as a patient. You still have the right to educate yourselves on what's happening. You have the right to stop your doctor, ask them more questions, and your nurse, ask them more questions that you have. There are no stupid questions when it comes to your diagnosis in your life. Feel free and empower yourselves to ask the questions needed to make the right decision about your body, because it's still your body, even though you're having to share it with your providers these days. Because that's really going to help make a difference, I think, overall in how you tackle your cancer diagnosis. So become educated, reach out to the organizations that are there for you for your specific type of cancer. Feel empowered to reach out to other patients to know that you're not alone in your cancer diagnosis. There's someone else that's always going through it with you. And also understand that even though you may have this type of cancer someone else does, no two cancers are going to be alike in a different person. So respect and understand each individual's person to have their own experience and take that forward. And then lastly, if you have someone, make sure they go to your appointment with you, because a cancer diagnosis is a huge, huge, overwhelming thing to hear. And even though you think you're going to hear all the questions, you're not going to. So whether it's a friend, a family member, somebody you met in a cancer group, which I highly recommend attending, even if you're not a group person. I wasn't, and then I came out with the most valuable experiences possible. Or even if it's getting a list of questions from, an organization like the American Cancer Society or the Melanoma Research Foundation or the many other nonprofits out there. Make sure you do it. You have the right to your due diligence, and it's only going to help in your journey. And that we're here with you. You're not alone. You're never alone.
Awesome. Thank you so much, Cassie. What a powerful way to end this discussion. Thank you again to all the panelists. Thank you to the audience for your attention and for the great questions. And we will now pass it over to lunch, the best session of the day. So thank you so much for being here, everyone. And hope you enjoyed GVCC. Sorry about that. Goodbye.